So today we will start the respiratory anatomy. First of all, conducting zone. Large airway consists of nose, pharynx, larynx, trachea, and bronchi. Airway resistance is highest in the large to medium-sized bronchi. Small airway consists of bronchioles that further divide into terminal bronchioles. Large number in parallel, so there is least airway resistance. Okay, now it sometimes is really confusing because sometimes we might think that terminal bronchioles might have more resistance, but because of this parallel connection, all of them being in parallel, there is least airway resistance. Okay, warms, humidifies and filters airs but does not participate in the gas exchange. Okay, so that is why it is called anatomical dead space. Now talking about a few things like goblet cells and cartilage will extend to the end of bronchi. Pseudostratified ciliated columnar cells primarily make the epithelium of bronchus and extend to beginning of terminal bronchioles, then transition to cuboidal cells. So how to remember this? Okay, so pseudostratified will extend till the beginning of terminal bronchioles. Just remember there is transition at the terminal bronchioles from pseudostratified to the cuboidal epithelial cells. Okay, so that is how you see T for terminal, and then there is transition at that stage. Clear mucus. Cilia clear the mucus and debris from the lungs, mucociliary skeleton. Okay. Now airways smooth muscle extend to the end of terminal bronchioles, sparse beyond this point. So basically smooth muscles are till the terminal bronchioles. Okay. Now talking about the respiratory zone, is basically the lung parenchyma consists of respiratory bronchioles. Okay, so respiratory zone begins at the respiratory bronchioles, remember that, and alveolar ducts and alveoli. Participates in the gas exchange, mostly cuboidal cells in respiratory bronchioles, then simple squamous cells in the alveoli. Cilia terminate in the respiratory bronchioles. So cilia is basically terminating at the respiratory bronchioles. Alveolar macrophages clear debris and participate in the immune response. Now you see here in this image, what you can remember is like you can see highest resistance in the medium size of bronchi. Okay, and goblet and cartilage is also there. In the bronchioles you can see it is simple ciliated cuboidal epithelium. Okay, simple. So see their terminal bronchioles, there was transition, isn't it, into the cuboidal cells. So here you can see there is cuboidal cells after the terminal bronchioles. Okay, cuboidal cells here you can see, right? Now cartilage is absent after the bronchi. In the bronchioles there are no cartilage, and smooth muscle is absent in the respiratory zone. As you go to the end of respiratory bronchioles, smooth muscle become absent. Okay, like it will decrease in the as it progresses towards the respiratory bronchioles. Now here you can see the classical features that in bronchi you can see goblet cells, ciliated cells. Okay, and they are pseudostratified epithelium, which is not present in the bronchioles. In bronchioles there are simple ciliated cuboidal epithelium. Smooth muscle is there in the trachea, but is also there in the bronchioles and terminal bronchioles, but cartilage is only present in the till the bronchi. Okay, now here you can see this small, sometimes they ask in the question even in the NBME that to recognize the type 1 pneumocytes and type 2 pneumocytes. So here you can see the type 1 pneumocytes is basically flat. Okay, simple squamous, so that's why it is flat, and type 2 pneumocytes are more like sphericals filled with lamellar bodies, isn't it? So those spherical granule filled vesicles are basically the lamellar bodies. Okay, remember that. And you can see the alveolar macrophages, which is also called dust cells, and capillary over there. Now what I have added from UWorld and other resources, I will tell you. Okay, here you can see I have written ciliated mucosal epithelium lines the pulmonary airway from the trachea till the proximal portion of the respiratory bronchioles. Mucus and fluid secreted onto this epithelium get uh, trapped act to trap particles suspended in the inspired air. The trapped particles are constantly swept upward from the bronchioles towards the pharynx by cilia that collectively beat in a direction of pharynx. The mucus and debris are then swallowed or expectorated upon reaching the pharynx. Now, there is one very important term called reed index that you need to recognize in the figure. Now, all the mucus glands, that is from B to C, you can see that is the thickness where mucus glands are present. So that is over the submucosa plus lamina propria. Okay, so it does not include the mucosa. Okay, just submucosa and lamina propria. So submucosa and lamina propria will be the denominator. So mucus glands over submucosa plus lamina propria, normally less than 0.4. Now here one more thing that I have added is nose, PNS, nasopharynx, and most of the larynx, lower half of the posterior epiglottis, these are the pseudo-stratified, whereas the oropharynx, laryngopharynx, and upper part of the posterior epiglottis and anterior epiglottis and true vocal cords are stratified squamous epithelium. Remember that. 3 to 10 micrometer size is cleared by mucociliary escalator, but when it is less than 0.1 micrometer, it can diffuse into the pulmonary capillaries, and whatever is in between the 10 in between gets phagocytosed by the dust cells. Okay, now here one very important image from UWorld is that the resistance will be maximum at the medium sized bronchi. Okay, so here you can see the resistance is being high at the medium sized bronchi over here, right? The resistance is peaking at this stage. Least resistance in the terminal bronchioles. This is because of the parallel connection and which slows the laminar flow. Okay, now I have also written that the upper respiratory tract, example nasal passages, mouth, pharynx, larynx account for about half of the total airway resistance. The remainder derives from the lower respiratory tract, which begins at the trachea and consists about 23 generations of the airways. Although resistance within the trachea and main stem bronchi is relatively high, it increases in the medium-sized bronchi because of the high turbulent airflow. Resistance is maximal between the bronchial generation 2 to 5, but drops in subsequent generation as the summated cross-section area massively increases, which is in the parallel connection, isn't it? So there will be decreased airflow velocity, allowing low resistance laminar flow. Okay, next. Now we will talk about the lung anatomy. Right lung has 3 lobes, remember that. Left has less lobes and lingula, homologous to the right middle lobe. So in left side there is no middle lobe, but only in place of that there is middle lobe, lingula. Okay, the middle lobe of left lung is basically lingula, which is a homologous of the right middle lobe. Instead of middle lobe, left lung has a space occupying structure called heart. A relation of the pulmonary artery to bronchi at each lung hilum is described as RALS, right anterior, left superior. Carina is posterior to the ascending aorta and anteromedial to the descending aorta. Okay, see, carina is just in the middle of the ascending aorta and descending aorta. So right lung is more common site of inhaled foreign bodies because right mainstem bronchi is wider, more vertical, and shorter than left if you aspirate a peanut. While supine, usually superior segment of the lower lobe, and while lying on the right, usually enters the right upper lobe. Okay, while upright usually enters the right lower lobe. Okay, so just remember the pull slow. Okay, that is how I remembered. Pull slow. Pull is for posterior segment of upper lobe or superior segment of lower lobe. If in the option there is no superior segment of lower lobe, then you can also choose posterior segment of the upper lobe. Be very careful about this. Okay, And I also have added here that foreign body aspiration leads to the right to left and poorly oxygenated blood oxygenated transported from the right to left versus alveolar dead space. So what is alveolar dead space? Alveolar ventilated but not perfused, for example in emboli. So how I remember that in emboli there is no blood going into the lungs, so that will lead to the dead space. Okay, that is how I remember quickly. But if there is aspiration, that will lead to the shunting, that blood will get shunted without getting oxygenated. That is why it is shunting in case of foreign body aspiration. Okay, now here you can see this is the CT scan. So here you can see the sometimes they label you and ask. So this is superior vena cava, you can see superior vena cava over here, and this is ascending aorta. Okay, this thing is ascending aorta, and this is pulmonary artery. Okay, this is pulmonary artery. Sometimes they can give you thrombus over here, and this is descending aorta. This one is ascending aorta in front, and descending aorta retroperitoneal. You can see the descending aorta. Okay, this is the carina. This is the carina, and this is the right bronchus, and this is the left bronchus. Okay, here in this X-ray you can see that this area of the right border of the heart basically coincides with the right middle lobe. So sometimes it is also called Silote sign. If the right border of the heart is obscured, then you should think of, because of opacity, then you should think of which, if the question asks you which lobe was involved, then choose right middle lobe. Okay, because that is called Silote sign. Okay, very very important. Now let's talk about the diaphragmatic structure. Structure perforating diaphragm at T8 level is the inferior vena cava and phrenic nerve. Okay, so this was also asked in AMBOS. Okay, self-assessment. And T10 esophagus vagus. So see the last word is 10 is for esophagus, O for 0, 0 is in 10, so esophagus, and also esophagus sounds similar like vagus, esophagus vagus, so that is in the T10. T12 there will be three structure. Simple way to remember is that one red, one blue, and the other is white. Red is the aorta, blue is the azygous vein, and the white is the thoracic duct. Diaphragm is innervated by C3, C4 and C5. Pain from the diaphragm irritation, example air, blood or pus in the peritoneal cavity, can be referred to the soldier. Okay, soldier is by C5. See, 5 looks like S, so C5. And trapezius ridge, that is C3. 3 looks like TR. 3, 3. Okay, 3, 3. So C3 and C4. Where trapezius ridge. They have made a mnemonic called T8 for vena cava. I don't know why they have made this mnemonic. Okay, so I 8, 10, X at 12, whatever. So 8 is for vena cava, and 10 is for esophagus and vagus, and T12 is for three structures, and that are red, blue and white. Okay, red is for aorta, blue is for azygous vein, and white is for thoracic duct. Remember that. Other bifurcations are common carotid bifurcates at C4, trachea bifurcates at T4, and abdominal aorta bifurcates at L4. Now there is a test called sniff test. Paradoxical movement moves up with inspiration on affected side, can see in fluoroscopy. So just imagine on inspiration the diaphragm should be flat, but the affected side, I mean the side where the damaged phrenic nerve is there, it will move up. Okay, right? So in sniff test, this is the thing. Okay, now I have added something that is pleura can be parietal pleura or visceral pleura. Pleura can be costal pleura, mediastinal pleura or diaphragmatic pleura. Now costal pleura is innervated by intercostal nerve, while mediastinal and diaphragmatic pleura are innervated by phrenic nerve. Visceral pleura sensitized to stretch only, supplied by autonomic nerve from pulmonary plexus. In patient with neck injury, it is important to remember that the long apices and cervical pleura extends above the clavicle and first rib through the superior thoracic aperture into the lung. Stab wound immediately above the clavicle. Okay, so this is very important. Okay, if there is stab wound above the clavicle and lateral to the manubrium, can rupture the, okay, can puncture the pleura and cause pneumothorax, tension pneumothorax or hemothorax. Okay. Ansa cervicalis arise from the C1, C2, C3 nerve. roots and innervates the sternothyroid and omohyoid muscle. Okay, sternothyroid and omohyoid muscles of the anterior neck. Penetrating trauma to the neck above the cricoid cartilage can injure this nerve. Okay, and chest tube placement. Okay, the tube transverses through the serratus anterior. Okay, there was a question on this, right? So tube will transverse through the serratus anterior muscle, intercostal, that is external, internal, and innermost, and parietal pleura. Thoracocentesis should be performed between 6th and 8th ribs along the mid-clavicular line, 8th and 10th rib in the mid-axillary line, and 10th and 12th rib along the paravertebral line. If the needle is inserted higher, there is risk of lung injury. Okay, insertion of the needle at these levels still risk the penetrating abdominal structure. For example, liver injury on the right if the needle penetrates it. Okay, so should be done above the superior border and not in the inferior border. Why? Because in the inferior border there is intercostal nerve. So how to remember? IN for intercostal, IR for inferior. So that is why whenever you do chest tube placement, do it superiorly. Okay, not inferior. Very important. This is basically representing the RALs. Okay, so here you can see the left pulmonary artery is superiorly while the right pulmonary artery is inferiorly. Okay, so that's it for this section. Meet you in the next section.